A1C. If the screen fasting blood glucose is abnormal, I would then get an A1C in that population. Additional labs for different types of rare stroke, such as vasculitis, rare hematological diseases, rheumatological diseases, or genetic causes of stroke could be considered, but because they are rare, they should only be done after the rest of the stroke workup is done, unless there's strong clinical indication that those are relevant to this patient's stroke. A thrombotic risk panel should not be done in most stroke patients, the exception being the patient who's under 40 with a patent foramen ovale that is thought to be symptomatic and has either family or personal risk factors for venous thromboembolism. For hemorrhagic stroke, it's a little simpler. We generally want a CBC, especially to look at the platelets, LFTs to look for liver disease and coagulation profile, look for bleeding diathesis. And you consider a UTOX in some patients, given the association with illicit drug use. So prevention of common post-stroke complications. Aspiration precautions in almost all patients, and we talk about doing the dysphagia screen prior to being given anything by mouth. This should be done in the ER, but it also should be considered on admission to the floor or any time the patient has any clinical change to make sure that they're still safe to swallow. You want to not insert or remove indwelling catheters to decrease the risk of catheter-associated UTI. You want to employ venous thromboembolism prevention, so this could be pneumatic compression devices, sub-Q heparin, early ambulation, getting the patient up and out of bed frequently if they are able. Early mobilization is good for many things, not just DVT prevention, but early rehab and good motivation might help with keeping patients oriented to daytime and perhaps help with delirium. Fall precautions, prevention of skin breakdown and ulcers for those patients that are more bedbound. It's important to elevate paretic extremities, especially if the paretic extremity is on the left side and the patient has significant neglect. The patient may not be aware that their arm is stuck between a bed and a bed rail if they have profound neglect, and it can result in injury and further increased risk of infection if they develop an open wound. And delirium is a common complication in stroke. It's estimated to occur in up to a third of patients with stroke. So keeping an eye out for that early and employing delirium precautions is important. We'll talk a little bit about discharge planning as well. As you're all likely aware, we must do stroke education and document this in EPIC for all patients. I'm going to show you an example of my stroke my information worksheet that has been recently revised and worked on by Deb Gregoire and should be in use soon. You want to use the stroke discharge navigator, and there are now both ischemic and hemorrhagic stroke discharge orders. The after visit summary for hemorrhagic stroke went live today, so keep an eye out for that. It's more specific to the hemorrhagic stroke population. For patients going home, you want to assess family and caregiver support, consider home health referrals if a home safety assessment is needed. If home PT, OT, and speech language pathology is needed, ensure the patients have the appropriate referrals in place. And ensure the patient or the patient's caregivers understand how to take or administer medications appropriately. And ensure that they're aware of the need for follow-up and who to call if they have questions. So this is the recently revised My Stroke, My Information sheets, which allows you to do patient education teaching that is specific to the patient and can help identify which type of stroke the patient might have had, what was the likely cause of stroke, what are their risk factors for stroke and what their goals are, a place to put their specific medications, to write their questions down, and gives them the information of the BFAST mnemonic for remembering stroke symptoms. So now I'm going to talk about stroke prevention. Now this obviously begins in the hospital before discharge, but there are many procedures that may be done after a discharge, and prevention is really continued for a lifetime, so I put it in a separate section by itself. So I'm going to talk about risk factors for stroke and helping patients to identify their individual risk factors, and talk about preventing stroke through lifestyle modification, medications, and procedures. So risk factors for stroke. We divide these into unmodifiable and modifiable. So unmodifiable risk factors you can't do much about. Things like age, the older you are, the higher your risk for stroke. Race and ethnicity, stroke risk tends to be higher in Black Americans compared with white Americans. Hemorrhagic stroke tends to be higher in Asians than in whites. Carotid disease tends to be higher in whites than other races. So your race often impacts your etiology, your mechanism of stroke, and your risk of recurrence. If you have a family history of stroke or early heart disease, if you have a personal history of stroke or heart disease, and there's others such as low birth weight, early adverse childhood events, exposure to particulate air pollution, or migraine with aura, which are things that, there may be things that can be done about these issues, but they take a much greater solution than an individual person can employ. In terms of modifiable risk factors, we have high blood pressure, smoking, high cholesterol, diabetes, atrial fibrillation, obesity, physical inactivity, poor dental hygiene, excessive alcohol intake, stress and depression, obstructive sleep apnea, and estrogen use. These are all things that an individual can do something about. In fact, according to the InterStroke study, which was published in The Lancet in 2016, reducing modifiable risk factors for stroke could reduce the number of strokes by up to 90%. Let's start with some lifestyle changes to prevent ischemic and hemorrhagic strokes. Obviously, smoking cessation and avoidance of illicit drugs, especially cocaine and amphetamines. Moderate alcohol intake, that's defined as less than or equal to 1 drink per day for women, or less than or equal to 2 drinks per day for men. Also to avoid a binge drinking pattern where little alcohol intake is done during the week, and then on weekends excessive alcohol is taken, which is defined as more than 4 drinks in a 24-hour period. Maintain a normal weight. Normal body mass index is 18 to 25 kilograms per meter squared. Want to reduce intake of fatty foods and red meat. Eat more fish, whole grains, fresh fruits and vegetables. Avoid processed foods. The best diets to prevent stroke are the Mediterranean diet, or a vegetarian or pescatarian diet. And I recommend these diets to all my stroke patients. And increase physical activity. The minimum recommended exercise to reduce your risk of heart attacks and strokes is a vigorous 30 minutes of exercise every other day, at least 3 times a week. Interestingly, exercise prevents stroke, heart disease, dementia, and other conditions irrespective of weight loss. So I just encourage people that the goal is to do the exercise each day. It's not to lose weight. And if you focus on just accomplishing the exercise and not focusing on the scale, it makes the reward immediate rather than a long-term goal. We don't know yet if stress reduction or treatment of depression will result in the reduction of recurrent stroke risk. Similarly, we don't know if improved dental hygiene would reduce future strokes, but these things make sense that you would want to treat them anyway, because they have treatments available and would make life better regardless. So we're going to talk about medications to prevent ischemic stroke. So we often use aspirin in many stroke patients. With select patients, we'll use clopidogrel. Aspirin Difenox, which is a combination pill of dipropionol and aspirin, has fallen out of favor since the PROFESS trial, which was published in the New England Journal of Medicine, I believe, in 2008. So I don't use that drug very much. It's extremely expensive and not very well tolerated, and it's proved to be equivalent to clopidogrel. Anticoagulants that are used include warfarin, and the newer agents, dabigatran, rivaroxaban, and apixaban. There are others as well that are in development. And then there's statins, atorvastatin, simvastatin, rosuvastatin, and many others. Atorvastatin and rosuvastatin are the high-potency statins we tend to use most in stroke patients. Simvastatin tends to have more drug interactions, so I tend to use it less frequently. The other cholesterol-lowering medications, such as Zetia or the fibrates, are not proven as effective at preventing stroke and are not used as often. Blood pressure control is extremely important for secondary stroke prevention. There are many agents to choose from. In general, the thiazide diuretics, ACE inhibitors, and angiotensin receptor blockers, and the dihydropyridine calcium channel blockers are the preferred agents. Beta blockers are less preferred for stroke prevention, but the most important thing overall is blood pressure control. Antihyperglycemics are also important, and there are many of these to choose from. And there are medications to help with smoking cessation, bupropion and varenicline, if appropriate for your patient, and nicotine replacement therapies as well. Hemorrhagic stroke has fewer options. By far and away the most important thing in secondary prevention of hemorrhagic stroke is blood pressure control. Again, by any means possible. The specific agents of choice are not as important as getting the blood pressure to target, which is normal tension. In general, we avoid antiplatelets and anticoagulants unless there's a compelling reason to use them. We sometimes are in the situation of patients having both atrial fibrillation and a history of intracerebral hemorrhage, and you have to make an individualized decision in those cases of what to do with their therapies. Statins are generally not indicated for prevention of recurrent hemorrhagic stroke. I only recommend their use if the patient has other clear indications, such as coronary disease or prior ischemic stroke. And then smoking